Hello again. Moving posteriorly, we will discuss hamstring tendinopathy, ischial bursitis, and piriformis syndrome, as well as intra-articularly, we will look at pain sources including impingement. Here are some subjective findings that may guide your hypothesis into one direction. Sitting pain with symptoms in the sciatic nerve distribution may lead you towards piriformis syndrome, where high hamstring tendon pain may also present with pain in sitting, as well as fast walking or taking off shoes. Pain here is deep and localized to the ischial tuberosity that may improve with warm-up but increase after activity. And finally, posterior impingement will be suspected with pain in positions of end range extension and external rotation. Here are clusters of positive exam findings and their associated diagnoses. We will go over these tests in lab. I also encourage you to discover the whys behind these diagnoses, whether they be impairments in muscle flexibility, strength, or biomechanical faults. You may also discover volume of training or activity to be at fault or as a mechanism of injury. Piriformis syndrome is irritation of a piriformis muscle and associated pathology of the sciatic nerve due to possible compression. It is caused by hypertrophy or spasm of the muscle or fibrosis following trauma. Not every presentation will have positive neurodynamic findings. However, you should assess via straight leg raise or slump with all of your patients you are suspecting that have piriformis syndrome. Treatment includes early use of anti-inflammatories. The goal of physical therapy is to address muscle imbalances and biomechanics that are associated with this diagnosis. Injections and medications are reserved for failed conservative management. This is another case report to use to guide you in managing patients. This protocol consisted of progressive glute strength and motor control, however, did not mention any manual therapy. I do feel there is a place for manual therapy to address any muscle spasm or fibrosis along with exercise. High hamstring pathology typically arises due to loading errors with repetitive compression and traction on the tendon during hip flexion and adduction. You may also see this in individuals that run or in those that perform yoga or Pilates due to the excessive eccentric and stretching loads placed on the tendon. It also has a higher prevalence rate in perimenopausal women. Pathology may occur at the point of insertion or in the midpoint of the tendon, with the insertional variations slightly more difficult to manage. What is found, looking at the histology of the tendon, is degenerative changes versus any signs of inflammation. Treatment of a rupture is similar to treating tendinopathy, but much more graded and prolonged. Early in the management of tendinopathy, load modification should occur where we educate the patient on activities to avoid while offering suggestions on how to stay active. As this active recovery is occurring, we begin progressive lumbopelvic stabilization, glute activation, and loading of the tendon starting with isometrics, followed by progressing to heavy, slow resistance training. Other considerations include soft tissue modalities, PRP, injections, and surgery for those recalcitrant cases. The next few slides show tables and pictures of a 3 to 6 month protocol for managing proximal hamstring tendinopathy. We will discuss some of these exercises in lab. As we begin to progress into loading the tendon dynamically, the prior slide shows isometrics. However, the next couple slides show more dynamic exercises. I use the stoplight analogy for patients. We actually would like to load the tendon so that the patient experiences about a 2 or 3 out of 10 discomfort during activity. However, that should subside within 24 hours. If pain is beyond 3, that is a red light to stop and go back a level of intensity. If it is not yet 2 out of 10, that is a green light to add more resistance. And if it is a 2 to 3 out of 10, that is a yellow light to slow and stay at this level of resistance for a bit. We will end the soft tissue discussion with disorders presenting with lateral hip pain. First, we have glute med tendinopathy and greater trochanteric bursitis. Those two represent extra-articular pathology. For some patients, pain associated with intra-articular pathology, including osteoarthritis and labral tears, will present with pain laterally. It has been termed a C sign when patients' hands make a C shape when they are pointing out their pain, when the pain is of an intra-articular source. Trochanteric bursitis is irritation and inflammation of the bursa between the greater trochanter and the IT band. It occurs in women more than men, mostly due to pelvis and hip morphology. It has been associated with a snapping hip occurring laterally. Pain acutely is more sharp, and in chronic phases become more dull. It is common to find pain in the L5 dermatome that occurs with lying on the involved side, walking, and stair climbing. Objective findings include pain with palpation, pain with resistive testing of hip abductors, as well as elongation of hip abductors. External coxa saltans or snapping hip is less common and caused by a thickened IT band or glute max tendon snapping over the greater trochanter. Oftentimes, patients present with other disorders along with external snapping hip, as you saw before. Positive findings for these individuals include pain with compression of the bursa and a positive Ober test. Snapping can be elicited in side lying with hip flexion and extension, as well as internal and external rotation. Biomechanical factors of excessive femoral adduction and internal rotation and pronation are common in these patients. It is also highly common to find glute weakness. Here you will find the common treatments of hip strength and manual therapy. Though less common, recalcitrant symptoms may lead to a surgical procedure of IT band release or debridement. Gluteal tendinopathy, often referred to as greater trochanteric pain syndrome, as it is a combination typically of tendon and bursa pathology, with tendon pain being primary. Often degenerative changes are found in the tendon, including histological changes, and small tearing. This often occurs with excessive tensile and compressive forces. Again, we see this more prevalent in females over 40 with pain exacerbated with single leg activities, including walking and stair climbing. Important to note is 35% of individuals with gluteal tendinopathy also complain of low back pain. Objectively, we see pain and poor performance of a single leg stance activity, pain and weakness of the hip rotators, as well as abductors, and poor movement patterns. Therapy has evolved from more passive modalities to more active physical therapy, with more long-term improvement noted with active physical therapy. Similar to hamstring tendinopathy, managing this pathology includes isometrics, progressing to heavy, slow resistance training while improving trunk stabilization. We also need to provide load management education and biomechanical counseling. This concludes the soft tissue pathology presentation.